Hi everybody, this is the Camtasia video for Chapter 4, Prenatal Care and Adaptations to Pregnancy. My plan is to put each chapter on its own separate Camtasia video. That way it just breaks things up a little bit. The first couple of slides are going to discuss the objectives for this particular chapter. We're going to be focusing on the goals of prenatal care, discuss prenatal care for a normal pregnancy. I really want you to learn the way in which you calculate the expected date of delivery and the duration of pregnancy. I want you to be able to differentiate between presumptive, probable, and positive signs of pregnancy, describe the physiological changes of pregnancy, identify nutritional needs, discuss the importance and limitations of exercise in pregnancy, describe patient education related to travel and common discomforts, discuss nursing support of emotional changes that occur in the family during pregnancy. I want you to focus on identifying special needs populations, and ones that we will focus on will be the adolescent, the single parent, and the older couple. I want you to apply the nursing process in developing prenatal teaching plan, identify the effects of medication ingestion on pregnancy and lactation, and review immunizations during pregnancy. So there are three phases of pregnancy: the antepartum, remember anti means before, so before birth or prenatal; intrapartum is during birth; and postpartum after birth. Who are the prenatal care providers that you might come into contact with as you get into the nursing profession? Well, the obstetricians are one of the most long-standing prenatal care providers. Much less frequently nowadays will you actually see primary practice physicians, or family practice physicians that are participating in prenatal care. Many of the family practice providers have moved away from doing OB care and have referred those folks either to obstetricians or to midwives. So that leads us to the next category, the certified nurse midwives. We talked about them quite a bit in our lecture today. We'll talk about them in some more detail. Nurse practitioners, although I would say that this is probably limited similar to the way that the family practice physicians are limited in their caring of OB patients. I do see some OB patients when they have other types of illnesses that they need addressed during their pregnancy, but I don't often care for women during their pregnancy. So what are the major goals of prenatal care? We want to ensure a safe birth for mother and child. That's first and foremost. And how do we do that? Well, we want to promote good, healthy habits, such as nutrition, exercise, appropriate weight gain, and we want to reduce risk factors that could pose risk to the baby. Teaching healthy habits will need to be a lifelong endeavor. It's not something we only engage in during the pregnancy period. Also, it's important to teach self-care, provide physical care, and also to prepare the parents for the responsibilities of parenthood, particularly if this is their first pregnancy. This is a significant life-changing event that is going to only really hit them, I think, when the baby is actually born. So preparing them as much as possible is very important. Prenatal visits, ideally you have a woman who is preparing to get pregnant and anticipating getting pregnant. Why do I say ideally? Well, remember how we talked about today in lecture that it is really important for women to be taking folic acid supplementation to help prevent neural tube defects such as spina bifida. So in a perfect world, you would have a woman and a partner who decide that they want to try to conceive, and they prepare physically for that. So the woman ideally is taking folic acid supplementation and a prenatal vitamin. Gestation of the woman at the first prenatal care visit is going to vary from individual situation to situation. What are some other factors that are involved in preconception care? Well, you want to identify risk factors that may be changed before conception. So if I have a couple that comes to me and says, boy, we really want to get pregnant. I know that they're both smokers. Well, I can counsel them on smoking cessation, and that can be something that can be changed before conception. So the goal there would be to reduce the negative impact on the pregnancy. Also, in your preconception care, you can focus on good nutrition and any immunizations that the woman might need prior to the pregnancy. And like we've mentioned on a couple of separate occasions, ensure adequate intake of folic acid to prevent neural tube defects. Remember that the neural tube can be affected very early in the pregnancy. So oftentimes a woman will not even know that she's pregnant, and the effects can already be taking place on the neural tube. And so therefore it's important that anyone of childbearing age, in terms of females, is taking folic acid supplementation. What else is involved in prenatal care? Well, you want to do a complete history and physical exam whenever you see that patient for the initial prenatal care. You want to be able to identify problems that may affect the woman and the developing fetus, and you want to ensure that a healthy pregnancy and delivery of the healthy infant occurs. What are some components of the initial prenatal visit? Well, you want to know her obstetric history. Has she had previous pregnancies? If so, what are the outcomes of those pregnancies? Were there any issues in past pregnancies, either with the mother or with the fetus? Menstrual history. Is her period regular? What is the flow like? Are there any premenstrual symptoms or associated symptoms? When was her last menstrual period? That is going to be key to helping you or enabling you to identify the expected due date. You also want to know if there's been any spotting or bleeding or any lower abdominal pain since her last period. Contraception history. What has she used in the past? What has she been using, if anything? It's also important to know, particularly if the woman has an intrauterine device in place. What is her medical surgical history? Does she have any comorbidities that could impact her pregnancy? One in particular that we're going to talk about later is something such as diabetes. Women who become pregnant and have diabetes have to be monitored extremely closely, and we'll talk about that in detail later on. But also knowing if she's had infections such as hepatitis, pyelonephritis. Are there any surgical episodes in the past, particularly related to the pelvis or the abdomen? You want to know family history, any genetic diseases that you could possibly be screening for or considering. Also the partner, who is the father of the baby, and what sort of genetic diseases might there be a potential risk for in the fetus. Look at the women and the partners to identify risk factors. And also look at the psychosocial history. Is the woman in a stable situation at present, whether it be the relationship with the partner or financially, socially, culturally, etc.? Physical exam, well, first of all, you want to identify any issues in terms of her general health. You want to get a baseline weight, because remember, weight gain during pregnancy is something that's monitored very closely, not only in terms of the entire pregnancy, but visit to visit. You also want to get baseline vital signs and evaluate nutritional status. Identify any current physical, social, emotional, mental problems so that those can be addressed. And also at the time of this initial visit, you would want to determine the estimated date of delivery. In terms of pelvic exam, this will be done by the provider, whether it's a midwife or a OB. Evaluate the size, adequacy, and condition of the pelvis. Like we talked about in the lecture today, certain sizes of pelvis and structures are going to be more advantageous for successful vaginal birth. And you also, the provider, excuse me, would also want to assess for the signs of pregnancy, and we'll talk about those in a little bit. Let me just go back really quickly to the calculation of the estimated date of delivery, because this is based on the last menstrual period. I will give you a calculation so that you can determine it based on the last menstrual period. I just wanted to mention that. Sometimes women will have an ultrasound as well that will also help with the more precise dating of the pregnancy. So what is the schedule of prenatal visits in an uncomplicated pregnancy? And that's really what we're going to focus on in the course of this lecture. From conception to 28 weeks, the woman would be recommended to come for prenatal visits every 4 weeks. From 29 to 36 weeks, every 2 to 3 weeks. And then from 37 to birth, the woman would come weekly. Certain laboratory and diagnostic tests are performed at various times of the pregnancy. There's a table in your book on page 46. I'm going to go over some of the highlights of the blood tests and the other diagnostic tests that are done during the course of pregnancy, but please take a look at this test. One, you want to know the woman's blood type and RH factor, and we're going to talk about the RH factor a little bit later on. You want to look at a CBC because you want to assess for any signs of anemia. Oftentimes, screening for sexually transmitted diseases will be done. So, for example, a VDRL or an RPR will be done, and that's assessing for syphilis. Also, a rubella titer will be done because if the mother who's pregnant gets exposed to rubella and gets infected with rubella, if she doesn't have immunity to it, that can be extremely detrimental to the fetus. Hepatitis B screening will sometimes be done. HIV screening will sometimes be done. A urinalysis and urine culture will be done. Sometimes a PAP will be done based on where the woman is in her schedule for PAPs. And sometimes in the first trimester, an ultrasound will be done, and that is a really very definitive way to assess for the exact delivery date and how far along the woman is. In the second trimester, a blood glucose screen is done, and this is usually done between weeks 24 and 28. And this is to identify gestational diabetes. And we'll talk more about gestational diabetes as we get further along in the presentations today. Also, the alpha-fetoprotein test can be done, and that's used to identify certain neural tube or chromosomal defects in the fetus. Amniocentesis can also be done, although it is a fairly risky procedure, and if this is done, it's usually done at 16 to 20 weeks. So, as I discussed in the previous slide, the woman's going to be coming at regular intervals during the course of her pregnancy, and there are going to be routine assessments that are done during each prenatal visit. So, one, risk factors. We want to review the risk factors that are known, and we also want to be continually assessing for any new risk factors. Vital signs and weight. Remember that during the course of pregnancy, there are expected weight gain measurements, and so you want to assess to make sure that the woman is not gaining too much weight or not gaining too little weight. And we'll talk about those parameters a little bit later on. Urinalysis, you want to be looking for protein, glucose, and ketones primarily. And in the next presentation, we'll talk specifically about why we want to be looking for those. Blood glucose screening, once again, there is a concern or a vigilance towards looking out for a gestational diabetes. The fundal height is a way that the fetal growth can be assessed. Remember, we talked about the three kind of parts of the uterus in today's lecture. Or excuse me, I guess it'll be yesterday's lecture by the time you all listen to this. The fundus is essentially the top part of the uterus, and that is going to be assessed at every visit so that the growth of the fetus can be assessed. Leopold's maneuvers are a series of maneuvers that can assess the presentation or the position of the fetus. This is important particularly as you get further along towards birth, because you want to be aware of the position of the fetus, considering breech presentations and if you're thinking about if a vaginal birth is going to be possible. Fetal heart tones or fetal heart rate is assessed at every visit, usually after 12 to 14 weeks. And we'll talk about normal parameters for fetal heart tones or fetal heart rate a little bit later. And then you always want to assess nutritional intake and any discomforts or problems since the last visit. Vaginal discharge during pregnancy. Bacterial vaginosis, or BV, is the most common vaginal discharge during pregnancy. It's caused in a decrease in the lactobacilli in the vagina, and which allows for microorganisms to proliferate. Women sometimes will notice a milky white discharge that is more than usual, and sometimes there's a fishy or foul-smelling odor to the discharge. Often there aren't any other symptoms, but it's important to screen for this and to be asking about this because it can be associated with preterm labor. So just a note, the importance of prenatal care cannot be emphasized more. It is crucial to reducing the number of low birth weight infants and reducing morbidity and mortality rates in mothers and newborns. So the prenatal care is really such a key component, and there are women of all ages and socioeconomic statuses that sometimes are not able to get access to this care. So making that available to the people that need it is very important. So what are some terms related to pregnancy? These are located in page 47 of your book, and I encourage you to really commit these terms to memory. So gravida, this is the number of pregnancies that the person has had, and it doesn't matter how long the pregnancy has lasted or if the woman actually gave birth. So if you hear that someone is gravida 2, that means they have had 2 pregnancies. It doesn't matter if they have any living children or actually if they've had any births. It only refers to the actual number of pregnancies. Nulli gravida means that the person has not had any pregnancies. Sometimes that will be indicated by gravida 0. Primigravida means that this is a woman who's pregnant for the first time. Multigravida means that the woman has been pregnant many times. Sometimes you will see an abbreviation G followed by a number. So gravida 2, and that indicates to you that this person has had 2 pregnancies. Para is the number of times that the woman has given birth to 1 or more children that have reached the age of viability. And remember, the age of viability is 20 weeks. Hint, hint. You'll need to know that. 20 weeks is the age of viability. Para refers to any action of giving birth, and it doesn't matter how many actual fetuses she gave birth to. And it doesn't matter how many of the actual children are living at present. So here's an example. If I say that someone is gravida 1, para 1, that means that she's had 1 pregnancy and she's had 1 delivery. If I say that someone is gravida 5, para 4, that means that she's had 5 pregnancies and she's had 4 births. So maybe she had an abortion, or maybe that 5th gravida is that she's pregnant again for the first time. A primipara is a woman who has given birth to her first child, and it doesn't matter whether that child was alive at birth or is living. Multipara means that the woman has given birth to 2 or more children in the past. Nullipara means that the woman has never given birth. Abortion. This word, I think, has a specific connotation in our culture. But remember that an abortion can be either spontaneous or induced or elective, so to speak. So sometimes people get pregnant and they have what we call a miscarriage. That would be also termed a spontaneous abortion. Sometimes people elect to have an abortion. So let me give you an example of how we use the letters and the terminology gravida, para, abortion, and then the last term is living that you might see. So you might see the initials G, P, A, L, which stand for gravida, para, abortion, and living. So let's say, for example, that you have someone who is G5, para 4, A1, and L3. So gravida 5 means she's been pregnant 5 times. Para 4 means that she's had 4 deliveries. A1 means that she had 1 abortion, whether that's spontaneous or induced. And then L was living, and I believe, if I remember correctly, I said 3. So she has 3 living pregnancies. 3 living children, although remember she had 4 live births. So that means that one of her children is deceased. Gestational age is the prenatal age of the developing fetus, and that's calculated from the last menstrual period. Fertilization age is the prenatal age calculated from the date of conception, which is usually 2 weeks less than the gestational age. And then age of viability is a fetus that has reached 20 weeks. And technically, at 20 weeks, the fetus is capable of living outside of the uterus. So the average pregnancy is 40 weeks. I got really upset when I realized that pregnancy is not actually 9 months. It's actually really closer to 10 months. Because by the end of my pregnancy, I was really uncomfortable and I didn't want to have to wait another 3 or 4 weeks. So just know that anywhere from 38 to 40 weeks is when you would expect delivery to occur. And that number is based on the first day of the last normal menstrual period minus 2 weeks. So here's how we calculate the expected date of delivery, okay? This is important to know. And it is called Nagel's rule. So first thing that you do is you want to identify the first day of the last normal menstrual period. Count backwards 3 months and add 7 days. If you need to change the year, you can do so. So let's use, let's show you an example. So let's say that a patient comes into my office and she says, my last normal menstrual period was April 7th or April 8th. Okay, so I'm going to count backwards 3 months. So I go to March, I go to February, and I go to January. And then I add 7 days. So I'm at January 8th, and I add 7 days, which would be January 15th. I'm going to need to change the year. And so the expected date of delivery would be January 15th of 2015. Does that make sense? Trimesters. The pregnancy is divided into 3 13-week parts. Aha. See, usually I used to think of a trimester as being 12 weeks, but no, that's where they sneak in those extra weeks on us. And it's important to know what occurs during each trimester, both for the woman and for the fetus. This is going to help you as a nurse give anticipatory guidance to the patient so that they know a little bit about what to expect. It's also important to identify deviations from the expected pattern. Okay, so let's talk about how we diagnose pregnancy. So there are a number of what we call presumptive signs of pregnancy. So amenorrhea, someone misses their period. That usually gets people's attention. So sometimes that will spur someone on to doing a home pregnancy test or to coming into their provider's office and asking for a pregnancy test. Sometimes the patient will develop nausea, breast tenderness. Sometimes the patient will develop some darkening pigmentation. Sometimes they'll have urinary frequency, fatigue, drowsiness, and quickening, which is this sensation of kind of a movement in the abdomen. Usually the quickening is not felt until fairly deep into the pregnancy. And I say fairly deep, it's more like halfway through the pregnancy. I wouldn't expect someone who's 8 weeks pregnant to feel quickening. It would be more something like 16 to 20 weeks of pregnancy where you might feel the quickening, which is kind of a fluttering in the lower abdomen. So remember that previous slide showed you all of the presumptive signs of pregnancy. So now we're going to talk about probable and positive signs of pregnancy. So probable signs, there's many. So Goodell's sign. Goodell's sign is a softening of the cervix and the vagina caused by increased vascular congestion. That would obviously be assessed by the provider. Chadwick's sign is a purplish or bluish discoloration of the cervix and the vagina and the vulva, and once again caused by increased vascular congestion. Important to know Chadwick's sign. Hint, hint, nudge, nudge for the test. Hager's sign is a softening of the lower uterine segment. Because of this softening, it's easier to flex the body of the uterus against the cervix, and that's called McDonald's sign. So once again, all of those would be done by the provider, but it's important to know these terms. Obviously, abdominal enlargement can be a probable sign of pregnancy. Usually by about the 12th week of pregnancy, the uterus can be felt above the symphysis pubis, and it'll extend to the umbilicus around week 20. So that's kind of a good benchmark to think about. Week 20, you would expect the fundus to be about the umbilicus. Braxton Hicks contractions are irregular contractions of the uterine contractions that are usually felt in the second trimester. Ballottement or fetal outline is a maneuver in which a fetal part is moved or displaced by the tapping of a finger on the cervix. Abdominal striae. Striae is just basically a fancy word for stretch marks. So as the abdomen enlarges, the skin has to accommodate for that, and it stretches, and then therefore stretch marks or striae develop. And then the final probable sign of pregnancy is the positive pregnancy test. Remember, what hormone are we looking for when we're assessing the urine pregnancy test? That test is picking up the HCG, and it's when someone goes to the CVS pharmacy and buys one of those home pregnancy tests, it's assessing for HCG. When someone comes into my office and asks for a pregnancy test, it's assessing for HCG. So it's the same thing. What are the positive signs of pregnancy? Well, one of them is the audible fetal heartbeat. And how do you determine that? A lot of times what's used in the office setting is a Doppler device, a little handheld Doppler. A Doppler is like a little ultrasound, basically, to be able to hear the heartbeat. And I have found in my practice that it is hard to hear the heartbeat before about 12 to 14 weeks. But some quite experienced practitioners, and depending on their technology, sometimes you can hear it at 10 weeks. Another device that can be used is a fetoscope. And so look when you're at your OB settings, ask them what they use to listen to fetal heart tones, and hopefully you'll get a chance to participate in listening to fetal heart tones. When I worked in the ER, anytime we had a pregnant patient in, regardless of what they came in for, we were obligated to assess for fetal heart tones. So I felt like I got pretty good at doing that. The fetal heart rate is going to vary based on the age of the fetus, but generally speaking, the low range is going to be 110 to 120 beats per minute. The high range is going to be 150 to 160. So if you can kind of commit those numbers to memory, that is kind of a helpful range, although like I said, it does depend a little bit on the age of the fetus. Be very careful when you're listening to or listening for fetal heart tones, because it's very easy actually to pick up the mother's heartbeat. And if you listen to fetal heart tones and you think, oh boy, I got a heart rate of 85, you need to ask yourself, is that mom's heart rate or is that baby's heart rate? If it's mom's, that's okay. If it's baby's, that's a problem. Second positive sign of pregnancy is the fetal movement that's felt by the examiner. And then finally, the ultrasound, which is sometimes done. And that can obviously definitively visualize the fetus. So what are some normal physiological changes in pregnancy? The changes are multi-system, from endocrine, reproductive, respiratory, cardiovascular, GI, urinary, and integumentary, and skeletal. So the pregnancy truly affects the entire woman. We'll look at it system by system. So number one, in terms of systems, the endocrine system, there's a dramatic increase in hormones that's going to affect all body systems. These hormones, like we talked about in yesterday's lecture, are essential for maintaining pregnancy. The estrogen and progesterone primarily. Remember what we talked about yesterday in the lecture. Initially, these hormones are produced by the corpus luteum. And then later, the placenta produces many hormones. Remember, we talked about the 4 primary placental hormones. And remember that the placenta actually morphs into an endocrine organ. It's temporary, but it does become an endocrine organ. And the primary role is to produce estrogen and progesterone in terms of the endocrine role in order to maintain pregnancy. The estrogen and progesterone are crucial to maintaining the pregnancy. What are the effects of the pregnancy on the reproductive system? Well, some of this is probably very obvious. The uterus becomes an abdominal organ, and it grows as the fetus grows. The capacity of the uterus is 500 mLs, so 5 liters, and that contains the fetus, the placenta, and the amniotic fluid.